Namaste. Today we are here to, we are coming with a heartbeat episode, and this episode is dedicated for cholesterol and cholesterol related malignancies which is going on. And time and again, when the diagnostics gives the report, patient get panic. And the panic is they see the reports and the values of the reference and the values of their own blood values. So there comes the role whether the cholesterol report, what to see and when to take it more seriously. So as I have earlier told also and repeating, first own the doctor and then you should go for the investigations. And in that purview, let us come when the lipid reports comes. So first of all, lipid report has to be done, or you can say the fasting lipid has to be done. And 8 to 10 hours of fasting is needed before you give your samples for the lipid profile. And lipid profile become very important when your family member is having means early coronary artery disease. Early coronary artery disease means if your parents are having means males less than 50 and females less than 60s are the risk factor of coronary artery disease. So if it is there, certainly you may have to evaluate in a holistic way from starting from your general evaluation, cholesterol, hypertension and other risk markers, if at all it is there or not. And blood parameter lipid is one of the important component in that. Now coming to the lipid values, how we see and how the guidelines are the authorities who have seen a lot of trials, and they have made some consensus that this value should be taken more seriously and some value we have to take the actions also. So these guidelines from the European and American College of Cardiology and even the lipidology, all are having, even the diabetology, all societies are having their own values, but all fall on some values which is well accepted, and those values are very, very important. So the most recent guidelines says that if your cholesterol, the most important thing is LDL levels. LDL level, HDL level, these are the two values which makes the difference whether the patient is having risk, high risk or low risk, or we can say the need of medications. So LDL is more than 190, this is a cutout value. This becomes very, very important for the patients and their family, because usually 190 plus is a marker that the patient is having some genetical abnormality of lipid metabolism, and it may be running in the family. It is not only the patient, it is the family who has to go for the genetical evaluation, and there we can get the risk finding that lipoprotein A level is somewhat, lipoprotein metabolism is abnormal. That is one thing. Second value, the second value which is becoming more important is HDL value. In our Indian population, it is the low HDL which is more risk factor than the high LDLs. LDLs and HDLs, they are the two components of the cholesterol values. LDL is called as a bad cholesterol because if its value is going high, proportionally your risk of developing heart disease, stroke increases. And if your HDL is going low or your HDL is low, it is a marker of abnormal metabolism, and in that situation the risk of heart diseases will be high. So it has been seen that if you are reducing your LDL level, your risk of heart attack reduces. And there are two types of treatment which we offer to the patient when we see the lipid profiles. One is called primary prevention, means the patient is not having any heart disease, but they are having risk factors. And LDL is one of the risk factors. If it is high, the chances of developing heart attack will be high. And in that scenario, the treatment will be different. And some patient, like the patient who has already developed heart attack, means myocardial infarction, or the patient has developed a stroke, or the patient is having atherosclerosis, other manifestation like peripheral vascular disease. In that scenario, we say that you are needing cholesterol medicines, and these cholesterol medicines are lifelong and they should be taken in a different doses. So we call it as a secondary prevention. We want that you should not to develop the second attack. For that point of view, we are giving. And in that scenario, means when you are having a secondary prevention, whatever your cholesterol levels are there, it doesn't matter for the continuity of the drug. Sometimes patients say that we are having our normal cholesterol or LDL are within normal, should I stop or not? So if you are in the secondary prevention, you should never stop your drug, because this drug is not only reducing your cholesterols, it reduces the inflammation and a lot of other pleiotropic effect we call as accessory effect, we can say. They are present and that prevent the progression of the disease, and the progression of disease is the atherosclerosis. So this cholesterol medicine is not only a cholesterol medicine, it is a medicine which is working on your atherosclerosis, which is the disease which is generalized disease, which manifest as a cardiac, which manifest as a cerebrovascular or a stroke, which manifest as a peripheral vascular disease. So to contain the disease, you have to take this medicine lifelong, even though your cholesterol has normalized. Coming to the diabetic patient, some diabetic patients say that my cholesterol has never been checked and I have been kept on the cholesterol medicines. So in our medical parlance, it is said that if you are having diabetes, your risk is compounded, means your risk is more than the general population. And some studies has even quoted that your risk of heart disease is equivalent to one attack of myocardial infarction. Means if you are developing diabetes, your risk is equivalent to the persons who has already developed heart attack. And that's why the norm is that to contain or to reduce the progression of atherosclerosis, which is ongoing silently in your body, we are giving the cholesterol medicine. But the dosing for the primary versus secondary is different. Primary we give 10 and 20 milligram doses of atorvastatin, and when you are in the going for the secondary prevention, there 40 and 80, means high doses are needed to reduce the inflammation. So in summary, the cholesterol is one of the important, means high cholesterol is one of the important risk factor. It is the cumulative, means over the time uncontrolled cholesterols which lead to the heart attack, and it is the LDL and HDL, not the total cholesterol, that we should focus. Sometimes a question arises triglyceride. So triglyceride is one of the accessory, it is not directly related to the heart diseases, and triglyceride is a marker of your poor glycemic control, metabolic, it is a component of metabolic syndrome also, means there are some risk factors which if not controlled will convert into the heart disease, diabetes and other type of atherosclerotic diseases. So in that scenario, your triglyceride become important. But if your triglyceride is more than 500, it means it is something related to the metabolism and genetics, and more than 500 triglyceride is a marker or risk factor for the pancreatitis, which is a very notorious disease, sometimes life-threatening also. So in that scenario, you have to take some medicines to reduce the triglyceride. It is not the atorvastatin which is usually prescribed. There are some separate medicines and dietary restrictions and physical activity. So for the cholesterol, the first treatment is lifestyle, exercise. Second comes medications, and these medications are mostly lifelong medication. For secondary prevention, means if you have already developed heart attack or stroke or peripheral vascular, it should be lifelong even though your cholesterols are within normal limit. So maintaining a normal lipid profile is the norm, and for that we prescribe the cholesterol medicine. Hope so most of the lipid related abnormalities and treatment I have covered. If you are having any questions and query, kindly post in the comment box. We will try to reach you and answer it. And thank you for watching. See you next time with some other topics. Thank you.